Good morning. My name is Nadine Mallak, and I'm a radiologist and nuclear medicine physician at Oregon Health and Science University in Portland, Oregon. I would like to thank LACNETS very much for having me here today to talk about understanding NET scans. This is the outline of my talk. There was a talk last year at this conference that covered in more details anatomic imaging, dotatate PET, and role of FDG PET. So for those topics, I'm just going to go over them briefly and highlight the most important point and answer the most commonly asked questions. And I will discuss for the first time the assessment of response to treatment, which is a very important topic, and there are a lot of questions coming on that. So to start off with anatomic imaging, CT or MRI, as we discussed in the prior talk, it is very important to have multi-phase CT of the abdomen that's done with IV contrast. And that's because neuroendocrine tumors are heterogeneous. And so a lot of times we could see tumors that are arterially enhancing that are pointed out by the red arrows here, for example. And so these lesions, we see them on the arterial phase. We do not see them on the venous phase. At the same time, there are some hypoenhancing lesions that we see better on the venous phase, and those are pointed to by the blue arrow. So for this reason, it's important to have the multi-phase of the abdomen. So this could be called multi-phase CT, triple-phase CT, or sometimes the order can come from your physician as CT with and without contrast. So if you want to make sure that the appropriate CT is being done, it's always a good idea to just check with the technologist performing the scan. So always asking the technologist, double-checking is a good idea. Now, MRI is a really good modality to evaluate certain organs. So for certain indications, MRI might be superior to CT, and that's mostly for liver, pancreas, and bone marrow. So for liver and pancreas, the enhancement of neuroendocrine tumors is similar in characteristics to CT. Now, MRI gives us more sequences to work with that are good at characterizing soft tissues. And one of these sequences is diffusion weighted image. So the DWI is going to highlight where the lesions are really well. And then we have a second sequence that's also very important for liver specifically. And this is delayed imaging using hepatobiliary specific contrast agent. So this agent is called Eovist in the US. Outside the US, so if you're in Europe or Australia, New Zealand, it's called Primovist. So it's the same molecule and they work exactly the same. On delayed images, if we wait 10, 15, or 20 minutes after contrast administration, what will happen is that liver cells are going to take up this agent and retain it. So as you see on this 20 minutes image, the background liver is bright. Tumors, because they're not formed of liver cells, they're formed of tumor cells, they do not retain that contrast. And so they're going to look as dark holes in the liver. So this sequence is very helpful to detect small liver lesions, and it's also very helpful to reproducibly measure them over time. So with neuroendocrine tumors, sometimes on the arterial phase, depending on the phase of contrast injection, sometimes we could see a little bit of blush around the lesion, which can make it look a little bit bigger on the arterial phase. So on the delayed phase after hepatobiliary contrast administration, we could accurately and reproducibly measure these lesions, which is very helpful not only for detection, but also for follow-up after treatment. So Eovist or Primovist is most sensitive method to detect liver metastases, and it's only used for liver. So if we're imaging other organs like brain, spine, we don't use Eovist. We use other contrast agents like Garavist, for example. So this is liver-specific agent. And it allows us to detect small lesions and to reproducibly measure them over time. So briefly, who needs an MRI, who needs a CT? So it's really depending on the indication. If for the liver specifically, liver is an organ that's commonly involved with neuroendocrine tumors. So if we need to characterize an indeterminate lesion on CT or on PET, MRI is very helpful. If we want, like for surgical planning, if it might change management if we detect small lesions, or if we have liver dominant disease that we want to follow up over time, then MRI with hepatospecific contrast is very helpful. For pancreas and bone marrow and also the brain, if we want to characterize lesions or if we have neurological symptoms. So for example, if we have a spine metastasis that might be compressing the spinal canal or causing neurologic symptoms, or if there's a lesion also compressing on parts of the brain, then MRI is very helpful to evaluate these areas. On the other hand, peritoneum is better seen with CT. So if we have disease that's mostly in the peritoneum, then we might not need MRI for that, and CT works very well. Now, the other organs that I forgot to write here is the lungs. CT is better for the lungs as well. MRI doesn't see the lungs well. So as you see, it's dependent really on the patient, like who needs MRI, who needs CT, depending on the indication. Other factors to take into consideration that the MRI is a longer exam. It's a little bit more expensive, might not be as available, but also does not deliver radiation. So the last point of small amount of radiation with CT, we don't worry about that if the CT is needed. And for adult patients, it's much less of a concern. But when we have younger people who are going to get a lot of scans over the period of their life, then it's good to be able to image them with MRI if possible and reduce the lifetime exposure to radiation. So now we get to PET. So somatostatin receptor PET or dotatate PET, first it completely replaced octreoscan, so no one should be getting octreoscan now. We have 3 FDA approved agents. The 2 that are commercially available at the moment are the gallium and the copper dotatate. Gallium dotatalk might be available in the near future. So the physiologic distribution, this is the normal scan that I'm showing here on the right aspect of the screen, and this is the normal distribution of the agent. So we see uptake normally in the spleen, in adrenal glands, in the kidneys, but we also see a little bit also in the liver background. Those agents are clinically equivalent. So I'm going to go over the minor differences between gallium and copper, but overall they're considered to be equivalent. So there are appropriate use criteria that were developed by the Society of Nuclear Medicine and Molecular Imaging. Those came out in 2018. They were updated in 2020 to include the copper dotatate, which is considered equivalent to the gallium agents. And there is one indication that I want to point out too, because there were questions about that. So if someone has symptoms or labs that are concerning for the presence of neuroendocrine tumor, but there was no neuroendocrine tumor seen on CT, so typically CT is the first study to get done, then it's appropriate to get dotatate PET after that. So because this is the most sensitive method to detect neuroendocrine tumor. So if a neuroendocrine tumor is present, dotatate PET is the most sensitive modality to detect that. So it is an appropriate indication for the scan. So difference between gallium and copper, this comes down to the physics property of the 2 agents, of gallium versus copper. The most important one that's particularly pertinent to patients is the longer half-life of 12.7 hours relative to the 68 minutes of gallium. This allows the distribution of copper dotatate to more remote areas. So this increased the availability of the agent. So now it can be available even in areas where no gallium generator is available to produce gallium dotatate. So that's the most important difference. There is this one study that compared copper dotatate to gallium dotatalk. Gallium dotatalk is overall considered similar to gallium dotatate. And this study showed that copper dotatate can detect more lesions than the gallium dotatalk. And this might be related to the physics properties of copper, which can allow us to have higher detection of small lesions. But this is not sure that it's going to translate to actually better performance of the scan overall. So still the guidelines consider them overall equivalent. And so there's really no need to travel to longer distances or to change institutions to get copper dotatate scan instead of gallium dotatate. So this is a very marginal difference that most probably is not going to affect clinical management. One of the questions that comes up is like, because copper is typically can be taken up by the liver, so are there safety concerns in patients with liver findings or liver disease? And there are really no safety concerns. The amount of radiation is very small and the amount of copper is very small. Also, some patients ask, well, am I going to be radioactive after this? And although it is a radioactive agent, the amount of radioactivity is very small that there is no concern for other people to be exposed to it. So you can be close to your family members and there's really no risk to them. It's always a good idea to hydrate, like whenever you get a radioactive agent, just like to clear it quicker from the body, but there's really no risk to other family members or other people. Now, a very common question is recommendation concerning somatostatin analogs. So the recommendation, the guidelines, is to stop short acting for 24 to 48 hours before the scan and to scan the patients at the end of the long acting cycle, like of the long acting somatostatin analogs. So what does science say about that? So the idea to stop somatostatin analogs is because somatostatin analogs are going to go bind to somatostatin receptors. And those receptors are also the target of our dotatate agent. So basically, the two are going to compete. So there was concern initially that if the patient is on somatostatin analogs and those are blocking some of the somatostatin receptor, will the diagnostic utility of the scan be lowered? Now, in order to see a lesion, in order to see a tumor, then we need the uptake in the tumor to be higher than the background organ. So for example, let's say that this organ here in the background is the liver, which we saw earlier that there is some physiologic uptake in the liver. So we need the tumor to take up the agent more than the liver in order to see it on our scan. So if there are somatostatin analogs on board, even if the tumor uptake is a little bit less, as long as the liver uptake is even less than that, then we'll still be able to see the tumor because the tumor to background continues to be high. And that's what the studies show on the presence of somatostatin analogs. So for example, this is one of the studies that looked into that. And so those were patients who were scanned before and after long-acting octreotide. And what they show is that in normal organs, the uptake was lower. So we see less uptake in liver, spleen, and thyroid after starting octreotide. The uptake in tumor, however, is not very much affected. So the tumor to background ratio is still high or a little bit higher. And there are also other studies that support this, and they show very similar findings. So even if the uptake in the tumor is a little bit less, we don't want that to happen if patients are being treated with PRRT, then we would want them to stop somatostatin analogs because we don't want the uptake of the agent to go down in the tumor at all. But for diagnostic purposes, this is less important. So although we still follow these recommendations overall to be consistent, it is much less important for diagnostic purposes than it is for therapies. So that's basically the bottom line on the use of somatostatin analogs. Dotatate PET before the start of PRRT can give us some information, some predictive information. So if the tumor takes up the agent significantly on the pre-therapy PET, then it is a good predictor of response to treatment. So if we have higher uptake on dotatate PET, this predicts a better response to treatment. Now, patients who have high amount of tumor, high tumor volume, then this can be a bad indicator. And the more heterogeneous the disease is, also the higher likelihood that it's not going to respond well to treatment. Now, post-treatment evaluation, this is a topic that's being discussed a lot now, and it is kind of uncharted territory. So I think it's important to talk about that. So we do rely on both anatomic imaging, CT and MRI, to assess the size of the lesion, but also importantly, the morphology of the lesion. And I'm going to show some examples later on. And somatostatin receptor PET or dotatate PET can give us a new baseline for the future. So there are some limitations in assessing only the size of the tumor because the size alone does not reflect some important features like the heterogeneity or the enhancement, or is it dead or alive? Even the size is the same. Sometimes we might have pseudoprogression shortly after treatment because of the swelling in the tumor. And some lesions, for example, in the bones, those are considered non-target by size criteria on CT and MRI. So there are some limitations to using CT and MRI alone. So to show you some examples to illustrate this concept, this is a patient at baseline that they had liver lesions, and then follow up 3 months after PRRT. Here the lesions are stable, probably slightly larger, but that could be from swelling after the tumor starts dying. And then in this case, the lesions continue to be stable or slightly smaller, even 2.5 years after PRRT. So that's a good response where the disease basically was slowed down, stabilized for a long time. So we saw progression in this case 4 years after PRRT completion, and we know that because we see new lesions in the liver, for example, like the lesions pointed out by yellow arrows. So we use CT to follow up. And for somatostatin receptor PET, the most important teaching point that I'm going to mention today is that we should not use the change in SUVs alone to indicate response or progression. So sometimes the uptake might go up even if the tumor is responding, and sometimes it might go down even if the tumor is not. So for example, when the tumor loses somatostatin receptor expression, then it might be more dedifferentiated and we'll see the uptake going down. So we should not rely only on the uptake levels. And I'm going to show examples of that as well. So the importance of somatostatin receptor PET after completing PRRT is to get a new baseline for the future and also to detect earlier some progression by the presence of new lesions. So if we have new lesions, then it might be progression. If some lesions that were present before have disappeared, then it is response. So we assess response on somatostatin receptor PET only by disappearance of known lesions or development of new lesions, but not by the change of SUVs. And this is one of the studies that also addressed that. And so here they followed patients with somatostatin receptor PET after treatment. So what they were able to see here is that dotatate PET detected progression earlier in the CT and MRI because it's more sensitive. So when there were new lesions, some of these new lesions were seen earlier on dotatate PET. However, they showed that there was no association between the change in SUV values and the response to treatment. So this is a very important point. This is a case, for example, renal primary, patient was treated with PRRT. On the left side is baseline. And after PRRT, we don't rely only on the level of uptake, but we see that there are many lesions that disappeared. So the disappearance of lesions is an indicator of tumor response here. Now, this is another case. Patient with small bowel grade 3 neuroendocrine tumor, metastatic to the liver and to the bones. And then we see good response at 3 months. Many lesions disappeared. And the response is sustained for 4 years. And sometimes we see continued decrease in tumor size or continued response even beyond the initial 3 months because the treatment takes time to work. So here, the 4 years scan is even a little better than the 3 months scan. So this was a very good response to PRRT. And in this case, the progression was seen 5 years after treatment with PRRT. And here we see new liver lesions that indicate tumor progression at this point. Now, this is another case with small bowel neuroendocrine tumor. So here the patient was treated with PRRT. So here we have disease response on the post-therapy scan. We see many lesions that disappeared in the liver. However, look at the liver lesions on CT. They look a little bit larger. But here it's important to look at the morphology. So the lesion is not enhancing as it was enhancing before, and this is because parts of it is dead. So these darker portions on the CT, those indicate necrosis or like tumor dying. So there is some swelling that we could see sometimes when the tumor dies. It's like there is a little bit of swelling that can make it look a little bit bigger, but it is still responding to treatment and it's not taking up contrast as much as it used to. So here it's important to look not just at the size, but the morphology of the lesion on CT and take that along with the findings on the PET. So this was good response to treatment. This is another case, pancreatic neuroendocrine tumor, and also we see a good response on the post-therapy scan. Many lesions on PET have disappeared, and on the CT, the lesion in the liver and the retroperitoneal nodes have also decreased in size. So that's a good response. Now, this is a case where sometimes we get a question, so patients were imaged before with gallium, can they be imaged with copper afterwards? So although ideally it's good to continue with the same agent, it is not a problem if someone was imaged with gallium and now they're imaged with copper. And typically we could interpret the scans even though the agent is different, especially that we should not be relying on changes in SUVs alone to tell if there is like tumor response or progression. So in this case, the patient was treated with PRRT, and on post-PRRT, the SUVs were higher in the lesion. However, it was smaller on MRI, and it continued to slowly decrease in size. So this was a very good response to PRRT. The tumors were getting smaller, and the response was sustained for at least 2 years after PRRT, despite the increase in SUVs. So that's why it's very important not to call progression if the SUVs are higher, because it's just reflecting the somatostatin receptor density, and it's not reflecting that the tumor is getting worse. Sometimes we get questions about PET MRI. Is PET MRI better than PET CT, or who should get PET MRI? So in PET MRI, what happens is like we get the dotatate PET, just similar to PET CT. We get the PET of the whole body, and we get just basic MRI sequences with it to tell us the anatomy, basically where the uptake is, but at the same time, PET MRI allows us to get dedicated body part MRI, and this is most commonly the abdomen, because this is the area of most common concern in neuroendocrine tumors. So the advantage of PET MRI is in patients who need abdominal MRI, this could be done at the same time as the dotatate PET. That's the biggest advantage of it, is the simultaneous acquisition of both scans in one session. So this is an example of a peanut. So this was a recurrent tumor in the left upper quadrant, and it's invading vessels nearby. That's why we see this branching pattern. So it's tumor going in vessels. In this patient also, we wanted to evaluate the liver. So here we see the liver lesions that we could evaluate them at the same time with the dotatate PET and with the delayed imaging after EOVIST on MRI. So that's the advantage of PET MRI, is patients who need an MRI and who need a PET can get them at the same time in one evaluation. Now, the role of FDG PET, this was discussed in details in the prior talk, so I'm going to go over that quickly. So basically, when the tumor is dedifferentiated and it's more aggressive, it's going to show more FDG uptake. And so it is a sign of bad prognosis, even in tumors that are of lower grade. So here is an example of heterogeneous disease where we have more aggressive lesions in the liver, and in the bones, we have lesions that some of them are showing more dotatate uptake, while others showing more FDG uptake. So it's kind of helpful to think about neuroendocrine tumors along this spectrum, where we have on one end the well-differentiated lower grade tumors that are typically dotatate positive, FDG negative, and then on the other end of the spectrum we have the more aggressive disease that's more FDG positive. Now in the middle we have a spectrum of diseases which are the higher grade 2 and the grade 3 well-differentiated tumors that could show heterogeneous uptake with both agents. So clinically, we get FDG PET when we're concerned that there's more aggressive disease. So this is an example of a patient who got 2 cycles of PRRT in 2019 and 2020, and then the patient decided to stop because of the pandemic, but they did very well, and they continued to be stable until they presented 4 years later with progression on CT. So at this point, when we did the dotatate PET, I want to point out to you this lesion anteriorly in the liver that is not taking up the agent. So it's like kind of a white hole on the dotatate PET. So here we were concerned that this might be a tumor that's aggressive and that lost somatostatin receptor expression. And so we did FDG PET in this case, and we see indeed that the lesion is aggressive and is taken up on the FDG PET. Now, this is another case where a patient initially, so this is the baseline scan on the left, and after the scan, the patient had debulking, so they had tumor in their pancreas, so it was taken out, and the lesions in the liver were taken out as well, and they presented 4 years later with progression. And if we look carefully at the CT here, we see that there are lesions showing somatostatin receptor expression in the liver, but some other lesions are not. And so those lesions on the left, in the left hepatic lobe, so that we see them as white holes on the dotatate PET. So, and in cases like this, we get FDG to assess these lesions. So who should get an FDG PET? So basically, typically, dotatate PET is first line for well-differentiated neuroendocrine tumors. We do get FDG PET if we suspect heterogeneous disease, if there are some lesions that we see or we suspect are present on CT or MRI but are not showing uptake on dotatate PET. So we get concerned that those are aggressive lesions that are not showing somatostatin receptors anymore, or if we have rapid progression. Now, FDG could be complementary to dotatate PET, so they could be done simultaneously in patients with high grade 2 and grade 3 disease, especially before PRRT, to better evaluate the tumor, or if surgery is considered with curative intent. So in those cases, FDG PET could be helpful, but not everyone typically gets an FDG PET. So with this, I come to the end of the talk, and I'm happy to answer any questions.